Hello everyone, I will be discussing bipolar disorder. I will be overviewing all of the different forms of bipolar disorder, but for the duration of this presentation, I will be focusing on bipolar I disorder. Bipolar I disorder is defined as a manic episode that may be followed by or preceded by a depressive or hypomanic state. Bipolar II disorder is a lifetime experience of at least one episode of major depression and one hypomanic episode. Cyclothymic is defined as a hypomanic and depressive period for at least 2 years, and for children it's 1 year, without meeting the criteria of bipolar I or II disorder. Substance abuse and medical conditions can also cause manic symptoms. The pathophysiology of bipolar I disorder is unclear. The current thinking is that bipolar disorder results when an interaction exists between the genetic predisposition of a person and psychosocial stress, such as abuse or trauma. Some biologic theories on bipolar disorder include chronobiologic theories, genetic factors, and chronic stress enkindling. There are also some psychosocial and social theories. A common chronobiologic theory is that sleep pattern has an impact on bipolar disorder. Artificially induced sleep deprivation is known to precipitate mania in some patients with bipolar disorder. It is possible that circadian dysregulation underlies the sleep-wake disturbances of bipolar disorder. Seasonal changes in light exposure also trigger affective episodes in some patients, typically depression in winter and hypomania in the summer in the northern hemisphere. Bipolar disorder is highly heritable. However, no one gene or sequence of genes is responsible for the pathology of bipolar disorder. Evidence suggests that the genetic etiologies of schizophrenia and bipolar disorders overlap. Wear and tear on the body is thought to contribute to cognitive impairment, comorbidity, and eventual mortality of those with bipolar disorder. Kindling theory states that the genetically predisposed individual experiences repetitive, sub-threshold stressors at vulnerable times. Mood symptoms of increasing intensity and duration occur. Eventually, a full-blown depressive or manic episode erupts. It is now accepted that psychosocial and environmental events contribute to the severity of the disorder and the frequency of the mood episodes. Some risk factors for bipolar disorder include family history of mood disorders, prior mood episodes, lack of social support, stressful life events, substance use, and medical problems, particularly chronic or terminal illnesses. Most patients with bipolar disorder experience significant symptoms before age 25. The estimated mean age of onset is between 21 and 30 years of age. Nearly 20% of individuals with bipolar disorder experience symptoms before the age of 19. No significant differences have been found between gender or race and ethnicity. The physical health assessment of an individual with bipolar disorder includes changes in severity of activity, eating, and sleep patterns, diet and body weight, laboratory studies, sexual practices, medication use, and substance use. The psychosocial assessment includes mood, cognition, stress and coping, and risk assessment. Now I will go into detail a little further. The patient may not sleep, resulting in irritability and physical exhaustion. Diet and body weight usually change during a manic or depressive episode. Laboratory studies, such as thyroid function and electrolyte levels, should be completed to detect evidence of malnutrition and fluid imbalance. Abnormal thyroid functioning can be responsible for mood and behavioral disturbances. In mania, patients often become hypersexual and engage in risky sexual practices. Current medications should be assessed to determine physical status. Manic or depressive episodes occur after patients stop taking their medication. The use of alcohol and other substances should be carefully assessed, and a drug screen should be ordered. If the patient is depressed, an assessment tool for depression may help determine the severity of depression. If mania occurs, evaluate the quality of the mood. Mania could present as elated, grandiose, irritated, or agitated. In a depressive episode, an individual may not be able to concentrate enough to complete cognitive tasks, and in a manic phase, judgment is impaired by extremely rapid, disjointed, and disoriented thinking. Feelings of grandiosity can interfere with executive functioning. Stress and coping are critical assessment areas for a person with bipolar disorder. A stressful event often triggers a manic or depressive episode. Individuals with bipolar disorder are at a high risk for injury to themselves and others. 23 to 26% of individuals with bipolar disorder attempt suicide. This diagram shows the physiologic changes that can occur in an individual with bipolar disorder. Extreme sadness, suicidal thoughts or actions, insomnia, changes in weight, stomach aches and pains, changes in sex drive, fatigue, hyperactivity, severe irritability, hyperventilation, increased heart rate, and muscular aches and pains. To be diagnosed with bipolar I disorder, at least one manic episode or mixed episode and a depressive episode have to occur. A mixed episode is defined as mania and depression occurring at the same time. Now I will go over the key diagnostic criteria for bipolar disorder. The diagnosis of bipolar disorder includes a distinct period of abnormally or persistently elevated, expansive, or irritable mood and an abnormally and persistently increased goal-directed activity or energy lasting at least 1 week and present most of the day, nearly every day. During the period of mood disturbance and increased energy or activity, 3 or more of the following symptoms, or 4 if the mood is only irritable, are present to a significant degree and represent a noticeable change from usual behavior. They include, number 1, inflated self-esteem or grandiosity. Number 2, decreased need for sleep. They feel rested after only 3 hours of sleep. Number 3, more talkative than usual or pressure to keep talking. Number 4, flight of ideas or subjective experience that thoughts are racing. Number 5, distractibility as reported or observed. Their attention is too easily drawn to unimportant or irrelevant external stimuli. Number 6, increase in goal-directed activity or psychomotor agitation. Number 7, excessive involvement in activities that have a high potential for painful consequences. For example, engaging in unrestrained buying sprees, sexual indiscretions, or foolish business investments. After the manic episode, it would be followed by a depressive state. Medications are essential in bipolar disorder to achieve 2 goals: rapid control of symptoms and prevention of future episodes, or at least reduction in their severity and frequency. Treatment includes mood-stabilizing drugs, which are listed below, and antipsychotics. Another form of treatment is electroconvulsive therapy. Lithium is the most widely used mood stabilizer. However, it is not a fully adequate treatment for all phases of the illness. Supplemental use of antipsychotics and benzodiazepines is often beneficial. Antidepressant therapy is not recommended in persons with bipolar depression because of a risk of switching from depression to mania. Electroconvulsive therapy may be a treatment alternative for patients with severe mania who exhibit unremitting, frenzied physical activity. Other indications for ECT are acute mania that is unresponsive to anti-manic agents of high suicide risk. ECT is safe and effective in patients receiving antipsychotic drugs. Desired treatment outcomes for individuals with bipolar disorder are stabilization of mood and enhanced quality of life. The effectiveness of treatment should be evaluated, and the level of medication adherence should be determined. Medication adherence is difficult to achieve but can be encouraged by involving family members in the care, encouraging the use of pill boxes, and medication reminders. For individuals taking lithium, evaluate their sodium intake because decreased sodium intake results in increased lithium retention, which can lead to toxicity. Evaluate the individual's coping mechanisms, personal relationships, and use of support groups. Mental health disorders are not commonly talked about. They are highly stigmatized. I will use this information and keep it in mind when working with individuals with mental health disorders or suspected mental health disorders. I will remember to respect them, promote their well-being, and make them the priority since they are the patient. Establishing and maintaining a therapeutic relationship while treating the patient is important and is key to successful outcomes. I will also use this information to advocate for my patients. More funding is needed for mental health programs, and one way to raise awareness about this is to advocate for those in need. Thank you for listening to my presentation on bipolar disorder.